myofascial pain interventions. I'm Andrew.
Kendall.
So our objectives are to discuss 3 problems associated with myofascial pain, identify supporting interventions to address these problems, explain how supporting interventions may address these problems. So 3 of the problems we came up with that might be secondary due to myofascial pain patterns would be a decrease in thoracic flexion range of motion, referred pain from trigger points, and any kind of postural dysfunctions, a bunch of different ones that could happen.
Alright, and this is just an insert from one of the textbooks that we found dealing with myofascial pain. So we're gonna focus on the erector spinae, and this is just some of the trigger points and referred pain that can come from this muscle group. The dark red circle, that's gonna be where the trigger point is, and the smaller red circles are where like the pain is referred.
So these are some of the interventions we found to address the decreased flexion range of motion. So for the max protection phase, we'll utilize soft tissue mobilization of the thoracic paraspinals, the rhomboids, and the surrounding other muscles. And also thoracic joint mobilizations. This will be a grade 1 or 2, more for like pain modulation. All right, for the mod protection phase, we'll do some stretching and lengthening of the erector spinae muscles, some thoracic spine active range of motions like flexion, extension, and then scapular retractions, and then dry needling, which will address the trigger points and kind of get out the tightness, and then some more thoracic joint mobilizations, but this will be a grade 3 and 4. Lie supine, we're going to do a single knee to chest. So I'll get her to bring one knee up to her chest and hold with her arms and hold for a few seconds and then release, and then I'll get her to switch legs. And there's that stretch, and then another one. For the active range of motion, we can just get the patient sitting and then do the flexion back to extension. Some side bending, just a normal active range of motion, just to kind of loosen up that musculature back there. And then for the minimal protection phase, this is kind of some strengthening exercises like Superman, extension on a ball, good mornings, and then more thoracic joint mobilizations, grade 3s and 4. So for the Supermans, so with this, you're trying to get your chest off the table while lifting your feet up at the same time. Go ahead. And this will work the whole thoracic extension musculature. And then extension on the ball. Took back. I'll go for good mornings first. So for this, just going right here, a little bend in the knees and then bending forward. This will work the lower kinetic chain while also working the eccentric motion of the back.
Okay, now we're going to talk about the interventions that were for the referred pain patterns from trigger points. So the first one that was discussed in one of the textbooks was the self trigger point release. So basically you just take, we don't have that device that's on the picture, but in the other picture on the right, they're just putting like a golf ball or maybe a tennis ball in the sock, and you're just applying pressure to the trigger point itself. This technique will relieve the pain and desensitize the trigger points and reduce inflammation. So by applying pressure to it, the muscle fibers in that area will relax. So basically you just have your patient identify where they're feeling that trigger point, and you can also just palpate to see. And you're just gonna apply it directly to that spot. Lean up against the wall, and then you just pull this forward. And then you just lean back to as much pressure as they can tolerate. And just hold it for a few seconds, come off of it, and go back. Right, and then the other technique or intervention would just be chirotherapy. Our Therex textbook talks about using the ice massage. So we know that chirotherapy can reduce inflammation and pain tolerance by decreasing that blood flow and decreasing the motor neuron activity. For the mod protection phase, we just want to focus on strengthening and stretching the erector spinae muscle group to improve in flexibility. By doing so, that will reduce some of the tension in the muscle fibers to relax the trigger points. So two that we have were the single leg to chest, which I just did, and then the other one can be child's pose. So we're gonna start prone and get on all fours, all right? And then push your hips back and get a good stretch. Hold that for a few seconds. You can come back up and then go back into it. And that's just stretching out that erector spine. Another one that you can do is the cat-cow. Jordan and Lacey demonstrated that earlier. Then for the mid protection phase, we want to focus on strengthening and increasing function. So the exercises that we listed, it will focus on strengthening and stabilizing the spine to prevent further trigger point activation. So one that we had was the Superman. I did that earlier, but to increase, I guess, the function with that, you can add a dumbbell to it. That's just gonna allow the muscles to strengthen more. And then another one that we have is the wall squat with the exercise ball. So you can just put the exercise ball on their back, do the wall squat with the weight. And the weighted wall squats will target the glutes, hamstrings, and abdominal muscles, which all aid in spinal stability. So strengthening these muscles will reduce strain on the lower back and decrease the trigger points. Now for the interventions to address postural dysfunction, we will, during the max protection phase, you just want to focus on making sure they know how to get to neutral spine. Doing so, it'll just make sure that they're cautious with, I guess, like the movements that they're doing throughout the day. So if they were bending over to pick something up, or if they were lifting, reaching up to grab something, it just allows them to know what position their spine is supposed to be in. And to find neutral spine, we know that it's a slight lordotic curve of the lumbar spine, so just want to tell them to have a slight tilt anteriorly. And to find that, you can you come against the wall? Against the wall. Yeah. You can just have them stand up against the wall, make sure their shoulders are touching, and then do a slight tilt back. And when their butt touches the wall, that's when you know you found your neutral spine. And then moderate protection phase, we have strengthening and lengthening of the erector spinae muscle group. These will target the muscles that are necessary for spinal alignment. So if we strengthen these, the patients could just have better posture overall. So two interventions we have are just back extension and the bird dogs. So all fours, and then if straighten your left leg, or you can do same arm, same leg. But that's that exercise. And then lastly, for the minimum protection phase, we have an RDL into a bent over row. The RDLs will target muscles in the posterior chain that are necessary for supporting the spine and pelvis during upright posture, and it can also release tension in the muscle fascia. So as you can see, the highlighted areas in red are the muscles that are targeted, which are all needed for spinal stability. We have muscles in the back, glutes, hamstrings, and also the abdominal muscles. So I'll demonstrate. First, doing an RDL, you just want to push your hips back, keeping your back in a neutral position. So we're gonna go down, and then once you get low, you just do a row. So Andrew, can you do this? And this would help with dysfunctional activities if the patient was bending over to pick something up. All right, we'll just start over.
All right, for our overview, myofascial pain patterns may lead to different impairments. These may include decreased thoracic flexion, range of motion, referred pain, postural dysfunction, and the main goals of intervention are the correct factors that cause muscle overload, alleviate trigger points, and strengthen the surrounding muscles in the areas that are affected. These are our resources. Mr. Harden?
So that good point, right? I know a lot of patients may bend at the knees too much or lean too much forward. How would you cue them? What are some cues you give them?
So personally, I'll just try to get them to get try to maintain a neutral spine. Really put their chin into their chest with a slight bend at the knee, and just watch them, make sure they're not doing too much bend at the knee. Just cue them not to.
You could also start with a noodle first instead of an actual barbell. Make sure they know how to properly do those movements. Also, with me, it helps to think about pushing my hips back to get more of a hip hinge than slouching over and bending over.
Any more?
What would drive the user be your modality of use or something like ECU?
So for the myofascial pain patterns, it involves trigger points. So that will kind of get rid of them trigger points while getting blood flow to the area and kind of getting out the tightness within.
So for one of your functional interventions was Superman, how would you explain to your patient that doing Superman is a functional task that you give, or how would you make that a functional task?
I guess I would tell them that it would strengthen the muscles needed for activities that would, they would need for flexion and extension. That exercise particularly, I'm not sure what you would be doing when maybe you're getting up out of bed, maybe you need those muscles to roll up, I don't know, but yeah.
So overall,
don't forget, I'm gonna jump in. So you got a patient come in, right? And I'm just hypothetically, from this scenario, from this condition. Oh man, I have a tough time standing upright in a grocery store when I'm pushing the basket. I'm always leaning over like this. And this how I walk in the grocery store pushing the basket. I'm saying this because I've had patients come to me and tell me this. I can't stand upright when I'm grocery shopping. So if you implement that in your med protection phase, the Superman exercise, so you let the patient know, well, Miss So-and-so, this is gonna help improve the muscle strength and also endurance of your back muscles that's required for standing upright while you're walking in the grocery store. So remember, you gotta tie your minimum phase intervention into a function. So that's a good question that you asked that. So y'all must know how to do that, because your patients gonna wanna know, how is this gonna help me with when I came to the problem. They coming to you with a problem. They're coming to you with functional limitation. And what you are doing, they're gonna wanna know, how is this helping me with my problem that I told you at the initial evaluation? I don't see how this is helping me. So if you just have them going through it and doing it and don't explain what is gonna help functional, then they're gonna leave saying, I don't know why that therapist had me doing that. I was just doing something. They're gonna go to another physical therapist and report that. Now you know why you had them doing it, but you didn't explain it to them. You see, it happens. All right. So strengthening your multifidi throughout the spine, because you have multifidi muscles going through lumbar, thoracic, and cervical, right? So major muscles required for extension of the back. So you strengthen those with the Superman exercise. So, good question.
I have a question. So, how would you describe a trigger point?
Okay, I'm gonna go to the end. So, in the end, on page 402, it describes a myofascial trigger point as a hyperirritable location, approximately 2 to 5 centimeters in diameter within a taut band of muscle fibers that is painful when compressed and that can give rise to characteristics of preferred pain, tenderness, and tightness. So basically, it's just like a knot, a highly irritable knot in the the muscle bands.
I don't
So
know.
good job with that. I like how you did that, because when you present professionally, that's what you want to be able to do. You want to be able to go to the literature. Don't try to ramble something off the top of your head. Go to the literature. According to so and so, this is what so and so says about that, because it's going to happen to you as a professional. Believe me, when you present and you go to these professional conferences, people are there. They're going to ask on what you may think are rambunctious, what they call it, rambunctious questions. All right, you're gonna get asked those type of questions, and people are just gonna ask you just to ask you. It could be something simple, but that's what you want to do. You want to go to what the literature says. Don't try to create something off the top of your head. Somebody may say, "Oh, I mean, y'all are doing kinesiotech with Dr. Benefit, right?" Somebody in the crowd may say, "You're doing a presentation on kinesiotech." Somebody may say, "Well, what are the benefits of kinesiotech? Why in the world are you even doing that?" Then you go to the literature, what the literature says about the benefits and science behind kinesiotech. You don't try to create something off the top of your head, you know. Good.
My question was gonna be about the dry needling. I mean, this may be no question, I don't know. But you know how they usually do the dry needling with E-stim? In this case, would they not do that? Well, not E-stim, well, stem. But would they not do that because of it being pain and not just tightness? You know what I mean?
Are you asking?
Or would
are
they
doing
benefit
both?
from stem being, because you know, they do the dry needling and hook it up to the stem machine?
Yep.
In this case, would you not want to do that because of pain? Because isn't that usually more so tightness? But because of the pain, would you not want to? I don't know. Does that make sense?
I get it, but in Dudley it didn't say anything about that, so that's what I read, and it didn't say anything on why. You have any?
No, we're not skilled with that quite yet,
Yeah.
so
It's
not sure.
So
how to
according to
answer that.
so-and-so, Dudley, I don't know.
But to speak to your question, there are a lot of different philosophies and strategies with dry needling. So my certification is in myofascial trigger point dry needling. And so we use the dry needle directly at the trigger point and try to stimulate a localized twitch response. Okay, so we try to that was reflexive contraction and then it releases. And so that would be, you know, there is a school of thought and people that would tell you that would be the appropriate type of dry needling to use. There are totally different schools of thought that use dry needling static, okay, in just certain areas along certain meridians and different things, and they may use E-stim with it. So they're just gonna use your judgment. Get the tools that are available to you and what makes sense to you. But E-stim with dry needling is pretty much like E-stim, period. So if you had a patient who had that, would you put E-stim on for that situation? We're just gonna be a little more direct with you. But the thought process with E-stim is gonna be similar to E-stim without. If that helps.
Any more?
I want to reinforce again. I want to reinforce this again. Because every semester, at the end of each course, I will read surveys. I will read student surveys, and I pay attention to what students say. And sometimes students will say, "Well, I wish I would learn treatments, how to treat this condition. I wish I would learn how to treat XYZ conditions." Now, I want to emphasize, when a patient comes and walk in my clinic with a condition, they may walk in my clinic with a stroke, right? A CVA. Patient 1 has a CVA, patient 2 has a CVA. The severity levels could be different. And the severity levels are different, and they could have also different problems, right? So do I learn to treat the CVA, or do I learn to treat the problems? I treat the problems associated with the condition. That irks me every time, and I be like, didn't I emphasize to them that we don't treat the condition, we don't treat pain. We treat the problems that are associated with them. So if we're treating the problems, there's nothing cookie cutter that can be taught to you to treat a condition. Does that make sense? So now that goes back to your assessment, being a thorough assessment, and you finding the problems, the impairments, and now treating those impairments that are causing the functional limitation. Does that make sense? That's the best thing that you can be equipped with. Because if a professor teaches you, say a professor teaches you, okay, this person has lateral epicondylitis. This is what you do. What if you get 2, 3 different patients come with lateral epicondylitis, but they got different problems? And you treat them, and you going by the template what the professor gave you for lateral epicondylitis, and that person comes and they're not improving. They're not getting better because you're using a cookie cutter template. Does it make sense what I'm telling you? So there is no cookie cutter template for treating conditions. You have to do a thorough examination and find the problems, impairments that that particular patient has, and you treat those impairments. It gets me every time. Oh, I wish we would have learned how to treat this condition. You're not treating that condition. You can get patients come in with the same condition with different problems, different impairments. You've been taught how to be a PT because you got to think and use your mind. You got to do thorough examination. This is what you get taught, how to be a PT. There's nothing cookie cutter. You know, we just give it frameworks, foundations. You build on those, all right? So good job going to the literature, because also you're gonna have to go to the literature as well, right? That's what we do, that's our profession. Who's next? All right, we got one more.